between hospital-based physicians and physicians not bound by EMTALA. Can you please walk the committee through the justification for having one resolution process for facilities and another for providers?
Yes, sir. One of the things that EMTALA does very specifically is it asks for emergency room physicians to make sure that they have to see every patient regardless of cost or anything like that. But again, you have a patient who may come in and the emergency room physician decides that this person needs to be seen by a surgeon because they have an infected appendix. Well, that person is going to have surgery by the surgeon. They're going to have anesthesia by the anesthesiologist. And you know, they may not necessarily be specifically bound by EMTALA, but once you're admitted into that hospital and you're in an emergency setting where it is impractical, unreasonable, and unsafe to transfer that patient, all the physicians that are on call during the time period where that physician's been admitted and has to be treated in a very short fashion by all those different providers, all those different physicians have to be, it has to be done in a timely fashion. So even though EMTALA may not directly apply to them, we have to take care of them. And the way we operate as anesthesiologists is you're taking care of many of these facilities 24 hours a day, 7 days a week, regardless of whether they have insurance, don't have insurance, we don't even ask.
So my final question for you, in supporting a benchmark concept with an arbitration backdrop, you mentioned that 4 recent state adoptions enjoyed the support of providers, insurers, and patients. So I want to clarify if your hospital partners supported these state efforts too.
So yes, they did. In Texas specifically, which the bill recently passed several weeks ago, all the stakeholders, emergency room physicians, Texas College of Emergency Physicians, the Texas Medical Association, the Texas Society of Anesthesiologists, the Texas Association of Health Plans, the consumer advocacy groups, including AARP, all supported the bill. It was a consensus bill. It was an excellent bill that was passed that involves baseball-style arbitration with specific guardrails to make sure that costs were contained within that framework.
Thank you, Madam Chairman. I yield back my time.
Gentleman yields back. The gentlewoman from California is recognized for 5 minutes for her questions. Ms. Matsui.
Thank you very much, Madam Chair. And thank you all for being here today. This is a very important issue. I kept hearing about it on my roundtables back home. As you may know, my home state of California already has some of the country's most robust protections against balance billing patients for certain procedures. In my district, I've already heard from many hospitals that in an increasingly fragmented healthcare system, there's concern their federal policy that may further discourage contracting between insurers and providers will have the unintended consequence of decreasing innovation and partnerships that are facilitating better and more coordinated care and reducing costs. As Congress considers solutions modeled after California law, I'd like to discuss how our state effort is working to influence market dynamics between healthcare purchasers and providers, and how those changes are ultimately impacting patients. Specifically, the reimbursement model in California benchmarks payments for out-of-network physicians at the greatest of 125% of Medicare, or the average contracted rate. Dr. Zaafran, can you discuss how using a median in-network rate as a benchmark may put downward pressure on future contracted rates offered by insurers?
Yes, ma'am. Thank you for that question. So median, by definition, means that you have certain contracts that are above that number and certain contracts that are below that number. And there's a reason for that. As I had mentioned in my testimony, there's a differentiator for why certain physicians have contracts that pay more than others. In fact, in Washington State, my specific company, Blue Cross Blue Shield, actually put out a press release touting a value-based contract that they signed from the standpoint that they're paying a premium, but they understand that the overall cost of care is actually less. So the ability to make sure that you're able to differentiate based on quality metrics, that a higher payment is due, is something that has to be preserved. If you keep everything at the median and not allow for those differentiators to exist, you're essentially kind of bringing everybody down to that number. And the other problem is that as new contracts are negotiated, if they're negotiated in a downward fashion, that median actually starts going down also.
Okay. Dr. Friedman and Mr. Zaafran, from each of your perspectives, if Congress were to establish a federal default